আসসালামু আলাইকুম। আজকে এসিআই আয়োজিত আপনার স্বাস্থ্যসেবা এসিআই পর্ব ৩ ওয়েবিনারে আপনাদের সবাইকে স্বাগত। আজকের টপিকস পিপলস অপারেশন টেকনিক্যাল অ্যাসপেক্ট। আজকের এই প্রোগ্রামে আমাদের দুজন অতিথি আছেন, প্রফেসর পি কে সাহা অ্যান্ড প্রফেসর আক্তার আহমেদ শুভ। আমাদের এই ওয়েবিনার অর্গানাইজড বাই অ্যাডভান্স ল্যাপারোস্কোপিক সেন্টার অ্যান্ড হার্নিয়া ক্লিনিক, সমরিত হাসপাতাল, ঢাকা, বাংলাদেশ। আমরা জানি আগস্ট মাস শুরু। এ মাসেই ঘাতকরা বঙ্গবন্ধু শেখ মুজিবুর রহমানকে সপরিবারে হত্যা করেছিল। আমরা তার আত্মার মাগফিরাত কামনা করি। আমরা প্রেজেন্টেশন শুরু করে দিব এখনই। আমাদের সাথে আছেন প্রফেসর পি কে সাহা স্যার, একজন রিনাউন্ড ল্যাপারোস্কোপিক সার্জন ইন বাংলাদেশ, আমাদের সোসাইটি অফ ল্যাপারোস্কোপিক সার্জারির এক্সিকিউটিভ মেম্বার এবং অনেকগুলো আন্তর্জাতিক সার্জিক্যাল সোসাইটিরও স্যার মেম্বার, এবং স্যারের আরেকটা পরিচয় হচ্ছে স্যার অ্যাডভান্স ল্যাপারোস্কোপিক সেন্টার এন্ড হার্নিয়া ক্লিনিকের প্রতিষ্ঠাতা। এবং এই সেন্টারের মাধ্যমেই স্যারের একটা মিশন এবং ভিশন হচ্ছে অ্যাডভান্স সার্জিক্যাল টেকনিক সবার মাঝে ছড়িয়ে দেয়। আমরা স্যারকে স্বাগতম জানাচ্ছি। প্রোগ্রাম শুরুর আগে স্যারের কাছে কিছু কথা আমরা শুনে নিব।
ধন্যবাদ। আজকে এই আগস্ট মাস আমাদের খুব দুঃখের মাস। আমরা এই দুঃখটাকে এই শক্তি হিসেবে মেনে নিয়েই আমরা এই দেশকে আগায় নিয়ে যাব। জাতির পিতা বঙ্গবন্ধু শেখ মুজিবুর রহমানের আশা, আকাঙ্ক্ষা, ইচ্ছা এবং তার সুযোগ্য কন্যা আমাদের প্রাণপ্রিয় প্রধানমন্ত্রী শেখ হাসিনার যে ইচ্ছা আমাদের দেশের মানুষের জন্য যে শিক্ষা এবং যে 5টা জিনিস বিশেষ এসেনশিয়াল মানুষের জন্য, কোনো মানুষ যেন আমাদের দেশে না খেয়ে মারা না যায় এবং ওয়ার্ল্ড ক্লাস যেন আমরা জীবনযাপন করতে পারি, আধুনিক যুগে যেন আমরা পদার্পণ করতে পারি, উনি যে ইচ্ছা নিয়ে কাজ করে যাচ্ছেন, আমরা ওনাদের সাথে আছি। আমরা এইভাবেই আমরা ওনাদের সাথে থাকবো ভবিষ্যতে, অবশ্যই আন্তরিকভাবে। আজকে ওয়েবিনারের টপিকস হুইপলস অপারেশন। এটা দেওয়ার উদ্দেশ্য আমাদের যারা ইয়াং সার্জন স্পেশালিস্ট হয়ে গেছে অথবা যারা হবে অথবা যাদের হওয়ার ইচ্ছা আছে, তাদেরকে এই জিনিসটাকে আমরা ট্রাই করব ইজি করার জন্য। আমাদের এখানে দেশে অনেক এক্সপার্ট আছে বিভিন্ন বিষয়ে এবং ল্যাপারোস্কোপির উপরও অনেক এক্সপার্ট আছে, কিন্তু এই একটা কমপ্লিকেটেড অপারেশনটাকে কিভাবে ইজি করা যায়, এর জন্য আমাদের আজকে এই চেষ্টা। আমি বলবো ডক্টর হাসফিককে জাস্ট অনুষ্ঠান স্টার্ট করার জন্য প্লিজ।
থ্যাংক ইউ স্যার। আমাদের মাঝে আছেন অর্থোপেডিক সার্জন ডক্টর আক্তার আহমেদ শুভ, অ্যাসিস্ট্যান্ট প্রফেসর, শহীদ সোহরাওয়ার্দী মেডিকেল কলেজ হাসপাতাল। আসসালামু আলাইকুম। আপনি ভালো আছেন?
মর্নিং।
আমরা আপনাকে ওয়েবিনারে স্বাগতম জানাচ্ছি। প্রফেসর পি কে সাহা স্যার এবং অ্যাডভান্স ল্যাপারোস্কোপিক সেন্টার এন্ড হার্নিয়া ক্লিনিক, সমরিত হাসপাতাল, ঢাকা, বাংলাদেশের পক্ষ থেকে আমাদের এই একাডেমিক মিশনে আপনাকে আমরা পেয়ে আমরা আনন্দিত। আমরা এখনই আপনার প্রেজেন্টেশনে চলে যাব। আজকের টপিকস পিপলস অপারেশন এন্ড টেকনিক্যাল অ্যাসপেক্ট। আমরা আশা করব যে খুব সুন্দর একটি প্রেজেন্টেশন আমরা আজকে উপভোগ করব।
ধন্যবাদ ডক্টর মাশফিক। আমার স্যার আমার সামনে বসে আছেন, দেখতে পাচ্ছি প্রফেসর পি কে সাহা স্যার। ওনার সালাম দিয়ে আমি শুরু করছি। এই গত জানুয়ারি পর্যন্ত আমি স্যারের আন্ডারে, স্যারের ডিপার্টমেন্টে, স্যারের ইউনিটেই কাজ করেছি এবং আমার সৌভাগ্য যে স্যারের মতো একজন বিশাল মনের মানুষের গাইডেন্সে আমি গত 1.5 বছর কাজ করার সুযোগ পেয়েছিলাম। এবং আসলে অনেক স্মৃতি পি কে সাহা স্যারের সাথে আমার পিতৃতুল্য স্যার। এবং আজকের যে টপিক হুইপলস অপারেশন, সেটা নিয়েও স্যারের সাথে আমার স্মৃতি আছে, কারণ আমার জানা মতে স্যারই প্রথম বাংলাদেশি সার্জন যিনি ল্যাপারোস্কোপিতে হুইপলস শুরু করেছিলেন এবং আমি তার সাথে থাকার সৌভাগ্য অর্জন করেছিলাম। তো স্যার আসলে বাংলাদেশের এই হুইপলস অপারেশনের নামের সাথে জড়িত থাকবে সারা জীবনই। তো আজকে আমাদের টপিকসটা যেহেতু আসছে, তার আগে আবার বলি ডক্টর মাশফিক যেটা বলেছিলেন, এটা আসলে শোকের মাস এবং আসলে আগামীকালই আমাদের 15ই আগস্ট। এই আজকে আর মাত্র 16 ঘন্টা পরেই সেই রাত্রে আসলে আমাদের জাতির জনকের সপরিবারে যে নৃশংসতম জঘন্য ঘটনাটা ঘটেছিল, সেই সময়টা এটা আমাদের সবাই আসলে বাংলাদেশের প্রতিটি মানুষ, শুধু বাংলাদেশ নয়, বাঙালি সারা পৃথিবী জুড়েই আমরা কিছুটা হলেও আবেগে আক্রান্ত আছি এই মুহূর্তে, অন্তত এই সময়টা। তারপর যেহেতু এটি প্রফেসর পিকে শাহ স্যার এবং এসসিআই ল্যাবরেটরিজ সবার যেহেতু প্রতি সাপ্তাহিক একটি অনুষ্ঠান, সেটি আমাদেরকে চালাতেই হবে নিয়ম রক্ষা করার জন্য হলেও। এই নিয়মের মধ্যে আজকে আমরা পড়েছি হুইপলস অপারেশনের বিভিন্ন অ্যাসপেক্ট নিয়ে। এখন আমি যদি আমার স্মৃতিতে শুরু করি, প্রথম যে আমি যখন ট্রেনিং পিরিয়ডে ছিলাম তখন আসলে হুইপল সার্জারিটা খুব ভয়ের একটা জিনিস মনে হতো। আমাদের সিনিয়র স্যাররাও সবাই করতেন না, খুব অল্প দু একজন করতেন, এবং সেটার যে আয়োজন এবং তার যে প্রিপারেশন দেখে আসলে আমরা যখন ট্রেনি ছিলাম ভয় পেয়ে যেতাম যে এটা মনে হয় একটা অসাধ্য কাজ, এবং এর আসলে কমপ্লিকেশন এবং ডেথ রেট এসব চিন্তা করে আমরা শিরে উঠতাম। আমরা কখনো চিন্তাই করিনি যে আমরা ওই রাস্তায় আসলে যাব। কিন্তু আসলে আমাদের সিনিয়র স্যারদের ঐকান্তিক প্রচেষ্টা এবং তাদের নিষ্ঠার কারণে আমরা যারা তাদের পরবর্তী প্রজন্ম, তাদের জন্য এই কাজগুলি সহজ হয়ে গিয়েছে। এবং এছাড়াও আসলে আরো অনেকগুলি বিষয় যেটা আমি বলবো, যে আমাদের ইনভেস্টিগেশন ফ্যাসিলিটিস, আমাদের পোস্ট অপারেটিভ ম্যানেজমেন্ট, আমাদের আইসিইউ অ্যানেস্থেশিয়া সবকিছুর ডেভেলপমেন্ট বাংলাদেশে হয়েছে, যে কারণে আসলে সেই দিনের সেই ভীতিপ্রদ অপারেশনটি এখন আসলে একেবারেই একটি সিম্পল অপারেশনে পরিণত হয়েছে। তো আজকে আমি আলোচনা করতে যাচ্ছি আপনাদের সাথে আমার টপিকসটা নিয়ে। তো আমি আমার টপিকসে চলে যাই সরাসরি। দেখতে পাচ্ছ সবাই?
হ্যাঁ হ্যাঁ, শিওর।
ধন্যবাদ স্যার। Our topic, Whipple's operation, its technical aspects. I'm Dr. Akhtar Ahmed Shubho, working in the Shoaib Sorority Medical College Hospital in the Associate Professor post of Hepatobiliary Surgery. What is the surgery? The classic Whipple's procedure is named after Dr. Alan Whipple, MD, the Columbian University surgeon. He did the first surgery in 1935. In fact, the surgery name is pancreaticoduodenectomy because we remove pancreas and duodenum mainly. By definition, a Whipple's procedure is a complex surgery to remove part of the pancreas along with gallbladder, common bile duct, the duodenum, and the portion of the stomach, that is pylorus, and surrounding lymph nodes. And there are parts of jejunum also. Depending on the types of surgery, sometimes we preserve the pylorus also. So if we see here, the normal anatomy in the left side, where there is a tumor in the head of the pancreas. So we have to remove, the Whipple's operation includes, you can see, the whole gallbladder, cystic duct, common bile duct, and it is the duodenum, the head of the pancreas, and few proximal centimeters of the jejunum. And then the other picture is the reconstruction of that. So this is the pre-Whipple's and the post-Whipple's picture. So after Dr. Whipple's, the Whipple procedure was introduced in worldwide by many surgeons tried, but in a few days they became reluctant to perform it because it had a high death rate. In the 1970s, it was 25% either died during the surgery or in the early postoperative period. Improvements in diagnosis, staging, surgical techniques, anesthesia, and postoperative care reduce the short-term death rate up to 4% in patients whose operation is performed by the experienced surgeons. At some major centers, the reported death rate is less than 1%, but at the rate may still can go up to 15% in patients where they are treated by the small hospital or by less experienced surgeons. So the mortality can be brought in less than 1% if we do it in a high volume center, in a high volume and expert team, then it is not a critical surgery at all. Because the Whipple procedure continues to be one of the most demanding and risky operations for surgeons and also for patients, the American Cancer Society has said it's better to have the procedure done at a hospital that performs at least 15 to 20 pancreatic surgeries per year.
Yeah.
It is a high volume, maybe it's a very short number, but in case of this complex surgery, it is a high volume. The New England Journal of Medicine found operative mortality rates to be 4 times higher at low volume centers than the high volume centers. So in high volume centers, less than 4%, but in low volume center, the death rate is more than 16%. Even in high volume hospitals, morbidity has been found to vary by a factor. The factor is 4 times more death in case of less experienced surgeons, so that the number of times the surgeons has previously performed the procedure, the number as many as procedures has been done by a surgeon, his mortality rate is so low. Okay, what are the types of Whipple's operation? There are 2 types. That is the standard Whipple's procedure that produced by Dr. Whipple's, that removes the pyloric antrum and pylorus also. But it has been modified by some surgeons, that is called the modified or pylorus preserving, and now it is most commonly practiced worldwide. It does not remove any part of stomach, and in spite of that, it keeps about 2 to 4 centimeters of duodenum. Like in the, it is the first picture you can see in the left, the pylorus has been removed. So it is the traditional Whipple's operation. And the right picture, you can see the whole stomach is preserved and a cup of few centimeters of duodenum is preserved. So it is a duodenum preserving pancreaduodenectomy. Now, when we'll do for the Whipple's operation? In the pancreatic head cancer, head cyst, and even the benign tumors, symptomatic benign tumors in the head, chronic pancreatitis involved in the head, ampullary carcinoma, bile duct cancer, distal bile duct, the neuroendocrine tumors around the ampulla of Vater, duodenal carcinoma, and in some trauma cases of the pancreas or duodenum, and other tumors or other organs that involves the pancreas, duodenum, or bile duct. When we will not do the Whipple's, when we will stop ourselves? In case of any metastatic disease, like the above indications with peritoneum, liver, omentum metastasis, or invasion of the base of the mesentery, growth adjacent organs like liver or other things. But duodenum is not a contraindication. But if the pancreatic malignancy has invaded the liver, then we will stop it. Distal metastasis to non-regional lymph nodes like pelvic lymph nodes or like this esophageal lymph nodes, then we think it's a very advanced disease. And when not contraindicated but not resectable, like when superior mesenteric vein or portal vein invasion is more than or 180 degree, or there is occlusion extending to the inferior part of the duodenum. The invasion of the superior mesenteric artery or celiac artery, 180 degree or more. Invasion of common hepatic artery with invasion of proper hepatic artery or celiac artery, or invasion of the abdominal aorta. When resectable? The resectable cases, which is without any doubt, there no tumor contact with superior mesenteric vein or portal vein, or contact but less than 180 degree, and there is no occlusion, and there is clear fat plane around the superior mesenteric artery, celiac artery, and common hepatic artery. And some cases are in the borderline resection, and those are tumor invasion or occlusion, 180 degree or more of the superior mesenteric vein or portal vein, but not exceeding the inferior part of the duodenum. Invasion of superior mesenteric artery or celiac artery less than 180 degree without stenosis or deformity, and invasion of common hepatic artery without invasion of proper hepatic artery or celiac artery. So arteries are more valuable, so we have to be cautious about the vessels. What are the usual complications of the surgery? The number one was the mortality that we have mentioned. But the Whipple's operation is technically different, but there is some complication also, like as usual every surgery, bleeding, infection. And here if we sacrifice the duodenum, there is delayed emptying of the stomach. And the main complication is the leakage from the pancreas or bile duct. Bile duct leakage can be manageable easily, but pancreatic leakage is a devastating thing. And there can develop diabetes, and diabetes could be temporary or permanent. What is the prognosis after this surgery? Overall 5-year survival rate is good. It is 20 to 25% in all cases. But 5-year survival rate is higher in case of node-negative patients who has early stage of malignancies, and especially on those cases which are trauma cases. There, in fact, the survival rate is very, very high usually. Regardless of the node status, most patients receive chemotherapy, radiotherapy, or both. But radio chemo is a debatable subject. Even the cancer specialists also vary about the doses and regimes, and we surgeons also vary. Like for myself, I don't prefer chemotherapy or radiotherapy in case of a clean-cut surgery having all margins clear. So it's a debatable thing of chemotherapy and radiotherapy. How can we predict the post-surgery prognosis? We can predict by tumor size, the venous invasion, the blood transfusion required during the surgery, and the resection margins, the lymph node metastasis, the tumor grading location, and the tumor cell ploidy. How can we do the Whipple surgery? We can do the commonly, that is the open surgery, and it can be also done by laparoscopic and robotic surgery. But in our country, laparoscopic and robotic surgery is not practiced due to our instrumental. There is no robot in Bangladesh at this moment, and laparoscopically also we have not reached the level yet, but we are trying. Minimally invasive Whipple's operation offers some benefits, such as lower blood loss and a quicker recovery in all complications, but it also takes a longer time, which can be hard on the body because these patients are usually physiologically very unstable and very difficult to allow operative time more than 6 or 8 hours. Sometimes a procedure may begin with minimally invasive surgery, but complications or technical difficulty require the surgeon to make an open incision to finish the surgery. Patient counseling is very much important because it's a very complicated surgery and there is chance of mortality and morbidity like pancreatic leakage. So we have to discuss in detail with the patient parties to get an informed written consent. And as I say, all of the patients are in fact had obstructive jaundice, and in case of advanced cases, a long time jaundice, 3 months, 4 months. So liver functions are almost always altered. The renal function is altered, and so we have to boost up his physiology by correcting those things. And some special precaution, like some we have to keep a ICU bed ready because many of the patients may need ICU bed, or no, not ICU, but we have to keep the patient in HDU at least for a good monitoring, even after a good surgery. And there should be some blood and some other instruments. This should be kept ready for the surgery. So before going to the Whipple surgery, I want to discuss in very short about some vascular anatomies, because Whipple surgery involves a lot of blood vessels, and the major blood vessels like abdominal aorta, like the inferior vena cava, like the portal vein, superior mesenteric vein, and the splenic vein. There is the gastroduodenal artery, the proper hepatic artery, celiac trunk. These are major blood vessels of our abdomen. So during the dissection, we have to go through these structures. So we have to have a good vision about the anatomy and its abnormality, so that we don't injure any vessels and we don't invite any bleeding, because in fact bleeding is a major cause of mortality in the early days of Whipples. So the artery is like gastroduodenal artery. It is a very prominent artery that we have to dissect and transect and ligate. It is a terminal branch of the common hepatic artery that supplies the stomach, duodenum, and the head of the pancreas. It lies behind the duodenum. So after we mobilize the stomach and duodenum, we can find the gastroduodenal artery. The branches of the first branch is the supraduodenal artery, and the gastroduodenal artery terminates as a bifurcation that splits into two arteries, that the right gastroepiploic artery and the anterior superior pancreaticoduodenal artery. These branches go downwards and they anastomose with the branches of the superior mesenteric artery and makes an arterial arcade around the head of the pancreas, and they supplies the bloods to the head of the pancreas. That is the issue, that Whipple suppression involve the head of the pancreas. So the blood supply of the head of the pancreas is from the branches of the gastroduodenal artery and the branches from the superior mesenteric artery. So this two artery control is very important for us, because if we transect the pancreas, we have to stop these two arteries before the transection. There is a venous trunk of Henle that we don't get very regularly, because it is just below the level of the superior mesenteric vein, but it does not incorporate in the Whipples, because it is mainly comes when we do the right hemicolectomy or gastrectomy. The venous trunk of Henle was first described by the Jacob Henle in 1868 as a blood vessel that runs anteriorly to the surface of the pancreatic head. It drains into the right aspect of the superior mesenteric vein, and its concave border of the average of 2 cm from the confluence of the superior mesenteric vein and the splenic vein. So during Whipples, we usually stay above the level. It comprises two tributaries like gastric and a colic. These two branch comes to make the trunk of Henle. The trunk of Henle is located in the junction between the omentum, small bowel mesentery, and the transverse mesocolon. So surgeons have recognized the clinical significance of this trunk during mobilization of the transverse mesocolon from the anterior surface of the head of the pancreas. This is the only step when we have to be careful. When we mobilize the root of the mesocolon from the head of the pancreas to reach the superior mesenteric vein, at that time the middle colic vein and the trunk of the Henle may disturb our way. If they are not prepared, they may get injured and there may be some unnecessary bleeding. Here we can see the trunk of Henle. The superior mesenteric vein, it unites the splenic vein posterior to the neck of the pancreas to form the portal vein. During the pancreatic mobilize, we first approach the superior mesenteric vein and we trace it and goes up to reach the portal vein. So we have to be careful about the superior mesenteric vein and its tributaries. Its tributaries are the mesenteric venous arcade, the ileocolic vein, the right colic vein, the inferior pancreatic vein, and the gastrocolic trunk. At the picture of all the venous system that form the portal vein, and before the portal vein there is a junction of the splenic vein and the superior mesenteric vein. So it's a quite clear vision, but we cannot see the portal vein until we dissect the neck of the pancreas. But the superior mesenteric vein we can get after removing the transverse mesocolon from the anterior surface of the head of the pancreas. The portal vein, it is a large vein, we cannot forget it, and no way to ignore. It brings all the oxygenated blood from the stomach, intestine, and the spleen and gallbladder and pancreas also. The principal tributaries of the portal vein are the splenic vein, the superior mesenteric vein, and there are pyloric vein and the cystic veins. We have to keep again and again look to the portal vein and the superior mesenteric vein again and again, so that we can see it and we can imprint in our brain. Whenever we go for Whipple surgery, we should never injure any of these structures. So we have to be careful about that. So I am giving the pictures again and again. The celiac trunk, the artery is dangerous, but it is quite easy to identify as its pulsatile movement. The celiac trunk is the second branch of the abdominal aorta. It arises from the aspect of the aorta, and the major branch of that are emerging after aorta. The celiac trunk extends up to 1 cm and divides into left gastric, splenic, and the common hepatic artery. This common hepatic artery will be in our eyes, because this common hepatic artery gives the downward branch, that is the gastroduodenal artery, that we have to go through and we have to cut it. But other branches we have to preserve. So we should be careful, and we also need to know the artery anatomy very clearly. There are the structures, the vascular system. The common hepatic artery is the sole artery to the liver, and it's the branch of the celiac artery to pass to the right. There are the anatomies that we almost know these things. We have to go through again and again through these things. The anesthesia is usually the general anesthesia or the epidural anesthesia, and the patient position is usually supine with all bony prominences well covered. We use a bridge or sandbag below the lower rib level to elevate the pancreas for better visualization. And there are lots of incisions for Whipple's operation in many centers, differs. Like usually we practice the rooftop bilateral subcostal incision. Some can do it with the right subcostal incision only. There are some midline, there Mercedes bench, reversal. Lot of incisions depends on the choice of the surgeons and the instrumental facilities. The intraoperative hepatic ultrasonography may be used by some centers to identify the lymph nodes and the growth. In addition, abdominal exploration may be undertaken as staging laparoscopy also before the laparotomy in patients with advanced disease who are suspected of being at risk for radiographically silent metastatic disease. So we can also give a laparoscopic staging before the open. Now we are going to start the key points of the surgery, the dissection. The self-returning retractor facilitates the general exposure of the operative field, but center to center varies. As our center, we don't have any Thomson retractor, so we have to do it manually with our surgeons and surgical team's strength. Once abdomen entered, the entire peritoneum is inspected, including the surface of the liver, to ensure no peritoneal metastasis, no hepatic metastasis. If any distant metastasis is found, we will abort the surgery. The hepatic flexure of the right colon mobilize and reflect medially. This is the first step we do. The Cocker maneuver performed where incision of peritoneum is made along the right border of the duodenum, allowing reflection of the duodenum and head of the pancreas medially. This allows the mobilization as well as palpating the involvement of the retroperitoneum and the supramesenteric artery. The ascending colon and the hepatic flexure are mobilized by using a cattle brush maneuver or right medial visceral rotation. To expose the third and fourth portion of the duodenum, we have to rotate in different angles and retract the duodenum and the head of the pancreas to the left side so that we can go underneath the duodenum and pancreas for the posterior dissection. The aorta, we have to reach up to we have to uncover whole of the inferior vena cava. So we have to see the whole part of the retropancreatic inferior vena cava clearly. Then we have to go more left to the anterior surface of the abdominal aorta also. We have to see the length of the aorta under the pancreas. The aorta and the crossing of the left renal vein are identified. The intervening lymphatic tissue should be mobilized as well. And the superior mesenteric artery will be seen arising from the anterior side of the aorta. Then we will think that the posterior dissection has been finished. Inspection and palpation of the superior mesenteric artery again and again to ensure that we are not doing any damage. Insertion of the common bile duct and transverse mesocolon and mobilize of momentum of the transverse mesocolon and colon. We enter the laser sac by incision of the laser momentum. Identify the middle colic vein flowing onto the superior mesenteric vein. Follow the superior mesenteric vein under neck of the pancreas to portal veins. And then we see the portal vein and we think that, okay. Then we go for some dissection of the gallbladder. The gallbladder mobilized is a retrograde fashion. The cystic artery cauterized or clip. The cystic duct mobilized to insertion into the common bile duct. Mobilize common bile duct and transect just insertion of the cystic duct. So we will remove the gallbladder cystic duct and the common bile duct. So the remnant will be the common hepatic duct. Cholecystectomy is performed with transection of the specimen at the common hepatic duct junction before the cystic duct takeoff. The common hepatic duct margin undergoes intraoperative pathologic analysis and is extended as necessary. Where there is a frozen section facility available, they can send that margin perioperatively so that the proximal dissection can be ensured. The port hepatitis, in case of port hepatitis, we incise the peritoneum in the port hepatitis, and sometimes also can coagulate it, or we can use harmonic also overlaying the port hepatitis. The celiac axis is located, and we want to remove all the fat and peritoneum from this arterial arcade so that we can see the right gastric artery and we can preserve it. And the lymph node in the common hepatic artery should be removed always. And the common hepatic artery should be dissected proximal and distal up to the gastroduodenal artery takeoff. We have to identify the common hepatic artery, right, left hepatic artery, proper hepatic artery, so that all the artery systems under our vision and we will not injure anyone. For the stomach mobilization, if we sacrifice when will we sacrifice the pylorus? If the neoplasm is bulky in the pancreatic head, or the tumor progressing to the first or second part of the duodenum already, the clinical positive regional lymph nodes noted at the junction precludes the pylorus presence. So then in that case, we don't preserve the pylorus, we will sacrifice the pylorus and we will go for traditional Whipples. And in that case, we will divide the stomach 2 cm proximal to the pyloric valve using stapler device or by clamps. But if the tumor is smaller and the criteria fulfills, then we will preserve the pylorus. And then the duodenum should be transected 2 to 3 cm distal to the pylorus. This duodenal cuff must be made long enough to withstand later division during creation of the duodenojejunal anastomosis. Now we'll go downwards for the mobilization and division of the jejunum. Divide the jejunum with a stapler or clamp, whatever surgeons like, or their facilities in that center. The ligament of teres is identified, and 10 to 15 cm distal to this, an appropriate vascular arcade should be identified where we should transect the jejunum. And then the ligament of teres is then mobilized with dissection of the third and fourth portion of the duodenum. This is brought under the superior mesenteric vessel to the right upper quadrant. Now the jejunum is dissected and cleared, and now the pancreas. And this is tunneling. This is the maneuver to separate the superior mesenteric vein and the portal vein from the posterior surface of the neck of the pancreas. So we have to retract the pancreatic tissue anteriorly by any sutures or our finger, and then we dissect the plan. We make the plan just below the neck of the pancreas and above the superior mesenteric vein and the portal vein by sharp or blunt dissections. When we can introduce our finger from inferior margin of the pancreas over the superior mesenteric and portal vein, and when we can reach the upper part of the pancreas and our finger comes out to the upper pole, then we think the tunnel is ready. Like this, when our both finger goes below the pancreas and above the portal vein and the superior mesenteric vein. Mobilization and division of the pancreas. Now, how will we transect the pancreas? Suture ligate superior and inferior pancreaduodenal vessels used for the vascular control of the and the traction also. So before we transect the pancreas, we'll give a few stay sutures from the inferior margin and the upper margin. The pancreas is then transected about 2 cm distal to the pylorus at the level of the portal vein, thus exposing the underlying superior mesenteric vein, portal vein, and the splenic vein confluence. If the tumor is adherent to the portal vein, superior mesenteric vein, or superior mesenteric vein, portal vein confluence, the pancreatic division plane may have to be revised more lateral distal, that means on left side, in order to accommodate the vein reconstruction. Transection can be done by knife, diathermy, or harmonic according to the choice of the surgeon and the center. We identify the opening of the main pancreatic duct, and there may be some bleeding points from the cut surface of the pancreas, we have to control it by suturing or by diathermy electrocoagulation. Portal vein separated from the uncinate process of pancreas by blunt or sharp dissections. Now, the mobilize the head and uncinate process from the portal and the superior mesenteric vein. This is very critical, and the last part. This includes taking the retroperitoneal tissue posterior to the superior mesenteric artery also. Small branches of the vessels either clipped or cauterized, or can be ligated with 3O or 5O proline. Once completely mobilized to the superior mesenteric artery, transect the remaining tissue with clips or harmonics or electrocautery, or in some center crush and clamp with hemostatic forceps, allowing en-bloc resection of the pancreas and associated duodenum. The pancreatic margin on the specimen is marked for a frozen section biopsy if that is available. So the specimen has been removed, and after removal of that, we have to go through the all cut margins and all sites of dissection so that there is no active hemorrhage. We have to control all the hemorrhages, and we have to go through for any remaining lymph node or anything we have left there. So we have to clear those extra dissection, and then at this moment the common hepatic duct is open. Some surgeons keeps it closed with some forceps or suturing, and some surgeons keep the common hepatic duct open, so that during this 1 or 2 hours of dissection and reconstruction, some bile can come out from the liver, so liver can be decompressed, and some things that it's we should clamp the common hepatic duct during the procedure so that no bile can come inside the patent cavity, and it may reduce the chance of postoperative infection also. So there are different thoughts for different surgeons. Now the anastomosis. In fact, the reconstruction is 3 reconstructions. As we know, the pancreatico-enterostomy, the hepatico-enterostomy, and the gastrojejunostomy. Only these 3 anastomosis. Among these, we first do the pancreatic anastomosis. So the pancreatic anastomosis is the most challenging and the most complicated and troublesome anastomosis also, because the major complication of this Whipple's operation is leakage from this pancreatic anastomosis. So it is the main focus for surgeons, how to prevent this leakage. So different institutes worldwide has tried different techniques, and we don't I will not say that any technique is better or any technique is worse, because any technique, if a surgeon practices a single technique and improves his skill, then this is the best option. So different surgeons do single types of procedure again and again and become master of that technique. So this is the main thing, that we should follow only one procedure, and we will practice how to develop this technique so that we can overcome our leakage chance. Now, there are about 13 procedures of pancreatico-enteric anastomosis, but most commonly uses are 3, those I am going to discuss. The first one is most popular worldwide now, that is the duct to mucosa. So the pancreas is not totally anastomosed with the jejunum. Only the pancreatic duct is anastomosed with a small opening in the jejunum, and the other part of the pancreatic surface is just sutured to the serosa of the jejunum. A 2-layer end-to side pancreatojejunostomy, also known as duct to mucosa reconstruction, is performed widely. This indicates full thickness pancreatic duct to jejunal wall closure. So full pancreas is not invaginated within the lumen of the jejunum. Only the duct is anastomed with the jejunal lumen. First, the posterior outer row of the interrupted seromuscular sutures is placed between the jejunal side wall and the pancreatic parenchyma. Then the jejunum is opened longitudinally anterior to this, a small opening that that might be equal to the pancreatic duct diameter. The inner circumferential layer of the interrupted full thickness sutures reapproximate the cut end of the pancreatic duct with the jejunal wall. The posterior sutures are tied inside the anastomosis. A pancreatic stent is sometimes placed, not always. Some surgeons like to give stents, some don't want. And the remaining sutures are tied on the outside. And then the anterior layer of the sutures is placed as a row of interrupted seromuscular sutures. So there are 4 layers, in fact, that duct to mucosa, most commonly practiced pancreatico-jejunostomy. Here we can see, first in the behind there is the posterior seromuscular sutures, that pancreatic parenchyma is attached with the jejunal wall only. Then the pancreatic duct has been sutured with the small opening of the jejunum. So after the tightening the parachute sutures, the pancreatic duct will go inside the jejunal lumen through that small window, and other pancreatic tissue will rest on the serosa of the jejunum. These are the different steps for this, and this is not the duct to mucosa. This is the pancreato-jejunostomy end to side without handling the duct. Here the pancreas is anastomosed with a long incision in the jejunum. Here the incision in the jejunum will be equal to that of the thickness of the pancreas. Here the first seromuscular layer of the jejunum is anastomosed with the pancreatic parenchyma, and then the cut surface will be introduced in the lumen of the jejunum, and same procedure, then the anterior layer will be done. In this case, the pancreatic cut surface will rest inside the lumen of the jejunum. It can be done end to side, that means pancreatic end in the side of the jejunum, or sometimes we can do it end to end. That is called the dunking procedure. It was in early days, it was widely practiced and it was the main options, but now the use of dunking procedure is been reducing. Invagination of the distal pancreatic stump into the jejunum can be performed in an end-to-end or end-to-side manner. The inner layer of the sutures is placed as described above, and the outer layer of the sutures is placed to the invaginate of the pancreatic remnant. This is useful when the pancreatic duct is not dilated, and when the parenchyma is too soft to hold against the jejunal seromuscular sutures. So, in case of narrow pancreatic duct, we cannot do the duct to mucosa anastomosis due to very small opening. It is very difficult to suture. So, in that cases, dunking procedure is a very good thing. Here we can see the pancreas has been introduced within the lumen of the jejunum. It can be end to end, or it can be end to side also. And after introduction into the jejunal lumen, then we can suture the pancreatic parenchyma with the serosa of the jejunum, like a stockings in the shoe. And now the new option is the pancreaticogastrostomy, not the jejunostomy. It has been used nowadays by around 9.5% surgeons worldwide, and this is the option of my choice. I am practicing for last year only this gastrostomy technique. Choosing a point in the posterior surface. In that case, we introduce the pancreas within the lumen of the stomach. It's very simple and very easy technique which everyone can practice, because pancreas lies under surface of the stomach. We need not to mobilize anything. You just need to introduce, like dunking, you just need to push the pancreatic cut surface within the lumen of the stomach, and there is a big capacity of stomach, so there should be adequate space. Here the interrupted sutures to join the serosa of the stomach with the pancreas, then inside the stomach wall of the size of the pancreas. So you have to do the first, before opening the stomach wall, we'll do a single layer of seromuscular suture interrupted with the posterior stomach wall with the pancreatic parenchyma. Then the same technique like pancreaticostomy. Then we make a incision over the posterior surface of the stomach at the size of the width of the pancreas cut surface. Then we'll introduce the cut surface within the lumen of the stomach, and then we'll complete the anterior layer by suturing. It could be continuous, it could be interrupted. And in some centers also, this has been done by using a linear stapler, linear cutter, like sleeve gastrectomy in bariatric surgery. We make a sleeve of stomach. Like that way, we do a sleeve gastrectomy and makes a separate part of the stomach, and then we introduce the pancreas in the same manner within that sleeve, so that the food chamber and the pancreatic juice chamber become separated. This is also being practiced in our country and worldwide also. Here, the pancreatic stump has been introduced within the lumen of the stomach. This is very simple and very effective and very compatible, as in the studies there, the chance of leakage, pancreatic leakage, is less in gastrostomy than the jejunostomy. Hepaticojejunostomy. Now the biliary reconstruction. The second anastomosis is the biliary. The common hepatic duct is to be introduced in the part of the jejunum. This is a single layer into and interrupted sutures end to side. The end of the hepatic duct has been introduced in the side wall. So after the pancreaticojejunostomy, if we do, then we have to take a short loop of jejunum to the common hepatic duct, and we have to remember that this loop should be not too long, not too short. There should not be any traction, and it should not be too loose. Like the child lying in the womb of a mother, like this, the loop should be circle from the pancreatic anastomosis to the hepaticojejunostomy, and then come out to the window of the mesocolon. So it should be a short but adequate loop. Okay, when we do the pancreaticojejunostomy, then we take about 4 to 5 centimeters of jejunum, and then the opening for the hepaticojejunostomy, and the opening should be not more than the width of the hepatic duct width, because during suturing, the jejunal opening may enlarge. That will misfit with the hepatic duct. So what we do, we can do in two techniques. The one is all interrupted. So we take the parachute technique, interrupted sutures, and what we can do is posterior we can do continuous suturing, and then we can do the anterior layer by interrupted sutures. Both are practiced worldwide. Usually when the hepatic duct diameter is enough, I mean more, very wide, in that case posterior layer can continuous suturing is very easy and less troublesome, and surgeons prefer it. But if the hepatic duct diameter is not that much wide, then all interrupted is better, as it has less chance of stenosis postoperatively. Like this, a small nick in the jejunum, and the common hepatic duct has been anastomosed with it, with this parachute technique by interrupted, and that posterior could be done by continuous suturing also. In case of pylorus preserving pancreaticojejunoectomy, the stomach and the duodenum, there is a cuff of duodenum, so duodenojejunostomy has to be done. The jejunum is traced distal to the biliary reconstruction and brought to lie anticolically. The cuff of the duodenum is revised for the adequate shape and positioning, preserving at least 1.5 centimeter of the post-pyloric duodenum to preserve the blood supply to the anastomosis. The anticolic end-to-side anastomosis between the duodenum and the jejunum is then created with a single layer of continuous suturing. Like here, the duodenum is preserved, and in the left picture, and then it has been anastomosed with the side wall of the jejunum. And in the other picture, there is the traditional Whipple, so no pylorus is there. So in that case, we have to make the gastrojejunostomy through the posterior of the stomach and making another new incision. Preferably, we do this gastrojejunostomy anticolically, and some center use linear stapler, some center use only hand suturing. And even we can make another Roux-en-Y loop also to make the gastrogenostomy to separate the path of the bile and pancreatic juice from the gastric content. So the Whipple's operation has been almost done, and now what we will do is the abdominal closure with we can irrigate with normal saline, and then some center prefers one drain and some surgeons prefer more drains, depends. And the fascia will be closed in running fashion using number 1 PDS suture, and skin is approximated using skin staplers. Patients transported to either recovery room or ICU. It is advised to stay in the ICU or HDU for 1 or 2 days. That should be better for the monitoring of the patients. But according to the protocol of the hospital, that should be followed. And in postoperative time, the better to keep patient in HDU, adequate pain management by Pethidine. The urine output is either we can flush the kidney with Lasix. Nasogastric suction should be kept for at least 2 days, and then from third day we start nasogastric feeding also. And drain collection should be monitored, and if in case of any suspicion, we should do the drain tube fluid analysis of amylase or lipase study that can predict us for the pancreatic leakage. The investigation in our center, we practice that after the first postoperative day, we do see the hemoglobin level and the complete blood count and the serum albumin, creatinine, and electrolyte minimally, and we do after every alternate day up to 7th POD these investigations. But if there are any other complication, we will do the other investigation also, of course. But without any complication, but we will monitor for at least 3 or 4 times investigations. Because why I said that? Because postoperatively, due to intraoperative biliary leakage or we open the stomach or duodenum, jejunum, there may be some chance of infections there. So the total blood count gives us a early notice of infection so that we can change or upgrade the antibiotics. And these are as malnourished patient, malignant patient, the albumin is critical for the successful anastomosis. So we have to monitor it because most of the patient needs serum albumin injections. So we have to monitor it. And due to obstructive jaundice patient, their kidney are sometimes compromised postoperatively. There can be renal failure. So we have to monitor the kidney function and the electrolyte also, because these patients have potassium and sodium abnormalities. So we should monitor it very carefully. And usual antibiotic what we use is cefuroxime and metronidazole we start. In case of any, we think that there should be a chance of infection, we go to meropenem. And we start amikacin after 2 or 3 days when the complete blood count shows there is a gross neutrophilic leukocytosis. Then we start, otherwise we don't go. Usually we complete with cefuroxime metro. And regarding analgesic, we go for Pethidine straight for 1 or 2 days at least, sometimes 3 days, and then we shift into tramadol, diclofenac, or paracetamol. Nutrition, we don't compromise with nutrition because it's an important factor for anastomosis leakage. So we have to calculate the TPN from the second POD. We start the TPN. In fact, first POD is from the second day, and we also do the early NG feeding. From the third POD, we will start 30 ml or 50 ml of water, dab water, or saline, and per hour, and then we increase into 50, 100 ml. When a patient can take the 100 ml per hour for 5 or 6 times, then we think there's adequate. We can give him regular diet. And we in case of some patients, we also add some vitamins and some minerals according to the investigation profile. And we encourage early postoperative mobilizing and walking from the second POD, and from the postoperative period, 0 postoperative period, to change the postures, and lung exercise by Medicizer, and the oral and skin hygiene, everything. And we encourage the earliest drain removal whenever the patient starts taking the food, and when we think that there is no leakage in the drain tube, so we remove the drain tube usually in the 5th POD or 6th POD. And we discharge the patient in the 8th or 9th POD, and we tell them to come to remove the stitches on 12th to 14th POD if there is no complication in that case. And in case of when we think there is some superficial wound infection or like that, then we don't discharge them. We keep them in our hospital wards, and we do this. And then, and after surgery, we tell our patients to come every 3 months to say hi and hello and to give some basic investigation so that we can monitor that there is any recurrence or not. And here is my experience for the last year, 2019. My team did 32 people's operation in my government hospital and my private clinics. And among that, we have lost 1 patient, and that was for leakage in the 18th POD. And there are a few social infections. And histopathology report, only 2 patients had positive margins, and we sent them to the oncologist. Thank you everyone for hearing for long discussions. And now I would like to invite you to ask any query about my presentation. Thank you.
Thank you, Akhtar Ahmed Shubho sir, Associate Professor. I just mistake it.
No problem.
Sorry for that. Thank you for your excellent presentation. It's a very informative presentation. And here in our discussion, Professor Bidhan Chandra Das is here, and he is here to encourage you for your excellent presentation. And there is some issue that Professor Bidhan Chandra sir has raised, that it should be spread the controversy and some issues to the learners, that the issue of pyloric preserving pancreatic duodenectomy. Sometimes how we decide we just preserve the pylorus or not, and Dr. Humayun Kabir is also there. He's also raised the issue to actually how we take the decision either we preserve the pylorus or not.
Okay.
This is the one thing.
Okay. Thank you. That I mentioned depends on the size and the invasion of the tumor. If we should first focus to preserve the pylorus. If it is possible, it's better for the patient for postoperative period. If the tumor involves the second part or the first part of the duodenum, then no preservation of pylorus. We have to sacrifice pylorus. If the growth is within the terminal common bile duct and the head of the pancreas, and no invasion with the duodenum, then we have to keep the pylorus. But in case of larger tumor and any chance of invading the duodenum, or within if the clear margin involves the duodenum, and there is periduodenal lymph nodes enlarged, and we think those can be malignant clinically, then we have to sacrifice the duodenum. No lymph node around the duodenum, growth confined in the ampulla of Vater or head of the pancreas, very small, clear cut margin we can predict from duodenum, no involvement of duodenum, we have to preserve the duodenum, pylorus. Have I answered it?
Thank you.
When to preserve?
I think it's quite clear. And,
yes. No lymph node, no duodenum involved.
Oh, okay, and that's why the comment. Yes, but that's comment. That's why pyloric preserving pancreatic duodenectomy usually done in the benign case and rarely done in the malignant case. And another issue in the dissection, the tunneling. If we start the tunneling first and the rest of the dissection we do later, then we can decide it is resectable, because resectability is quite different by encasement of the vessels. If we start the dissection from the tunneling, that we can then we can quite sure that we can either
sure. Tunneling should be done earlier, not fast. The cholecystectomy, those I say, these are the steps. But for the operability assessment, we have to first cauterize the duodenum and the colon, and we have to go through the pancreas. We have to mobilize the mesocolon from the head of the pancreas. We have to see the supramesenteric vein and the supramesenteric artery. Then we go for the tunneling. Okay, not the cholecystectomy, and then we'll go for the cholecystectomy. And sir is right that we do cholecystectomy later on. We have to mobilize this colon, duodenum, and the mesocolon and the tunneling, and then we decide yes, it is operable, resectable or not.
Thank you, sir. There is another issue that Professor Vidhan Chandra Das has also raised,
Yes.
the drug resistance, because he commented one study on BSNMU that the 90% of the bile organism is quite resistant on regular cephalosporin dose. And what is our option, and what is your choice in that case to encounter this resistant organism?
Oh, thank you. In case of drug resistance, at first, when we do the first POD, we get the complete blood count. If we don't see any sign of infection, we don't bother for any change of antibiotic. But in case of when the blood picture shows there is a systemic infection, then we add traditional like amikacin. But still, that if that does not control that, then we can think for the higher antibiotics that is not traditionally used. But if there is no chance of infection, there is no sign of superficial infection or systemic infection, we cannot go for blood culture randomly. But there is a way that Vidhan sir has done in the BSM. I was also his student at that time, that the paroparty bile culturing from the common bile duct, syringing the bile and sending that culture, and the culture report can help us postoperatively choosing our antibiotic. Okay, but that culture also can take 2 to 3 days time. But we have to start antibiotic from the paropartic period. So we can start for our traditional antibiotics. And about the cefuroxime cephalosporin resistance of 90%, I don't think. Of course, it's a commonly used drug throughout the country by pharmacy men. So there is a chance of resistance, definitely. But in our setting, in fact, in our government hospital, we cannot go outside ciprofloxacin, ceftriaxone, and cefuroxime. Meropenem is also in supply, but that is in minimum amount. So we have to go through our traditional antibiotics, then culture, then follow clinically, biochemically. If needed, we can shift. Then any antibiotic is welcome, if there is indicated. Then, but we can start with cephalosporin and metronidazole from the start, I think.
Mashfiq.
Yes, sir.
Sir,
Can I say something?
Definitely, sir. You can join the debate.
I request Professor Vidhan pass his comment and his experience regarding this. I request to the Professor Vidhan Chandra Rai to say something regarding his comment of this topic, please.
Okay, we hope also that the Professor Vidhan will see Professor Vidhan in the screen also. So thank you, Professor Akhtar Ahmad Shubhu sir, for your nice comments. And you have I just simplified it. You have to encounter the drug resistance and the less supply in the government hospital, and the poor condition, the economical status of our patient, and the additional use of antibiotic. That is the doctors, the super specialist doctors, the victim, but the main additional use is usually done by our the pharmacy man or the quack people, and our non-aware or unaware people, general people, that they are irrationally or just frequently they are taking the antibiotic without any registered physician prescription.
Yes.
Thank you, sir. There is an issue that the diabetes and Whipple surgery. Some says that after Whipple surgery, the patient develop diabetes. Can you hear me, sir? Can you hear me?
Yes. Yes.
There is an issue that the diabetes and the Whipple surgery.
Whipple. Yes. Yes.
The patient previously they didn't have the diabetes, but after Whipple surgery, gradually they have the diabetes. just a few comments about the issue. Thank you.
Thank you, Dr. Mushfiq. Whipple surgery removes the head of the pancreas and the neck of the pancreas. And for diabetes mellitus, the insulin secreting cells mostly reside are in the head region of the pancreas. So after Whipple surgery, the insulin producing part has been removed. Okay, so theoretically there is more chance of diabetes mellitus for patients after Whipple surgery. But practically, in my short experiences, I have not seen such patients that develop the diabetes postoperatively that they did not have previously. I have not noticed I have done more than 100 cases, and I have seen no such patients in follow-up. In my opinion, theoretically, I already said that there is a chance of temporary and permanent diabetes mellitus. It's a complication of Whipple's, definitely. But maybe as I have not found this complication, maybe the cause is in most cases where we do the Whipple surgery, almost all are malignant cases, not the trauma patient or the benign case. Those are in fact very rare. So the malignant head of the pancreas already loses a big insulin secreting mass, or they have been destroyed by pressure effect like this. And maybe they have adequate insulin secreting compensating cells throughout the body and the tail of the pancreas. Maybe it may be a cause. I think histopathologists or endocrinologists can answer better than me for regarding this question. Thank you.
So I think this is not yet solved, because if sir, you have said that the insulin secreting cell is in the body and tail, and in Whipple's operation we just remove the head. So why the patient develop diabetes after Whipple's surgery? I think that's more research.
No, the head, there are insulin secreting cells. Those are removed. So part of the insulin secreting cell is removed. That's the truth. So there is a chance of insulin deficiency. It's also theoretically true. So chance of diabetes is there. That is also theoretically true. But I think my belief is there is some compensatory mechanism that develops with the period of time, so that the patient can adjust with the remaining insulin secreting cell in the body and tail, I think.
So another issue is there, because the Whipple is a big operation. There is a issue of fitness of the patient, and but the postoperative and perioperative mortality and morbidity rate is quite high, and sort of bit of time-consuming operation. And sometimes patient is not agree to do the operation. Sometimes patient is not even fit for the operation, and there is some endoscopic therapy is also some palliative issue is there. So what is your comments about that?
Fitness, it's a malignant case. Patients are malignant, so their fitness must be poor. It's a natural thing. And especially those patients come to us after 2 or 3 months of jaundice, after taking local treatment, then pharmacy treatment, then COVID, like these things. So most of the patients are physically and physiologically unstable when they came to us. But after 2 or 3 days or a week admission, we prepare those patients to take at a level for the surgery. We cannot expect that the patient will be very much fit. It is not possible, because the patient has jaundice. One thing is endoscopy, that is the ERCP. There is a role of ERCP for the preparation of the patient. If the jaundice bilirubin level is too high for a long period, then that it affects the hepatic function and the renal function, everything. So those patients are difficult to prepare for surgery. So before surgery, we have to prepare his liver and kidney. So in that case, I think ERCP is a good option for stenting, to reduce the bilirubin, to revert back the liver, the normal function, and the kidney flushing out. Then the patient will be better for surgery. In fact, it's a difficult decisions, and you have to calculate many things. Okay, number one is the stage of the disease, so that if our delay of 2 weeks or 3 weeks will make the operable case inoperable or not, we have to think about that. We have to think about the financial condition of the patient, if we keep the patient longer in the hospital, will they be able to afford or not? And the thing is, in many cases, there is some different thoughts of surgeons, like when to refer a patient to ERCP or when not, which level we should maintain. In many journals, there are 18 milligram per DL of bilirubin. Above that, 18 to 20, they should send for ERCP stenting, reducing the jaundice, and do it earliest. But in some centers, they are doing without any ERCP, even in bilirubin more than 30. But one thing has to be mentioned, that you have to be prothrombin time or coagulation profile must be within normal limit. But if you cannot pull down the prothrombin time, then you have to send for ERCP to reduce the bilirubin and revert back the liver for its quite normal function, and then the prothrombin time will be corrected. Because it's in fact not a clean cut decision that you have to tighten the plus and minuses, and then you have to reach the decision. And regarding the fairness of the patient, just one day earlier, one patient admitted in my clinic for Whipple's procedure in the night, but in the morning the patient left and called me, "Sir, I am afraid I will go home and take again decision, and then I will come." Like this, there are lots of patients doing these things. Okay, but we have to offer them. We have to offer the options, the curative, the palliative, like these things. And some patients, many patients have financial problem because it's a complicated surgery, so hospitals stay is more than 7 days. There is nutritional support, there is higher antibiotic, so the cost is a bit high for poor patient. So some patients are agreed, they think and know it, but due to financial crisis, they cannot afford. And the other is for in the government hospital, where I practice mostly. Every week I do 1 or 2 Whipples in government hospital in my setting. But the problem is the patient
you have started the general surgery in the COVID era also.
COVID yes. With some precautions, we should not delay. We should not avoid any malignant surgery, because COVID kills patient, but malignancy kills at least 30 times more patients in the world in last 6 months. So malignant patients are going to die. You cannot stop that for COVID. So we have to stop.
So another issue, sir. Can I take one issue from Professor Vidhan Chandra Das?
Oh, sure.
Can I take one issue?
Yes.
You said that, sir, that during operation it sometimes become inoperable, and previous preoperative imaging also sometimes misdictate or cannot dictate the actual scenario of the tumor. And sometimes after starting the operation, we can see that the tumor is quite inoperable.
Yes.
And in other case, that's Professor Vidhan Chandra Das has just put the issues that the lymph node dissection, that's the quite challenging. Then sometimes it is more challenging than the actual the tumor resection. The primary tumor resection is quite more challenging than the lymph node dissection sometimes. So what is your practice? What is your regular practice in case of lymph node dissection, and what is the standard and radical dissection, and what is your satisfaction of the lymph node dissection in your operative practice? Thank you.
Thank you. As I mentioned last year, I have to keep 2 cases. That was the margin was involved, not cleared. It happens in some cases. Like we are in Bangladesh, the reality is like yesterday, a gastroenterologist was with me online. That MRI and intraluminal ultrasound, those are better options for diagnosis than CT scan in many options soft tissue. But I said there that the reality is the reporting efficiency of MRI is not up to mark in our country at the moment. So I cannot depend on the report of MRI for a life-saving critical surgery. That's why we have to go with CT scan. As the CT scan reporting system has been achieved a level in our country over a few years. So like these things, we have to manage things, not according to book always, the things. and sometimes we see the borderline tumor that operable or not. My advice will be we can call Dr. Mashfiq for diagnostic laparoscopy, so he can stage that is it should proceed or not. Number one.
Right.
Number
Exactly.
two is I
People
mentioned
send the patient to Advanced Laparoscopy Center, Samarita Hospital. Sir.
yes. And the other option I said after the incision and entering the abdomen, we can assess a bit because lymph node are enlarged, cannot be enlarged independently. There are when the lymph nodes are enlarged, we can assess where and how many lymph nodes are there by palpating and by watching before any dissection. We can go for that. We can assume some idea. But in sometimes we think plus minus, we can proceed or not. In that case, we should proceed. And the lymph node, if you think we have to go for every corner to search every lymph node. But
Sir,
in
one
some
question.
cases,
Sir, one question. Do you ever recommend any patient for lymph node scanning
no,
preoperatively by
no,
PET scan?
no,
PET scan. By PET scan, do you ever lymph node
no,
scanning
not
by
yet,
PET scan?
not yet, not yet, not yet, not yet.
Do you think this should be done?
Should be done if PET scan is less costly, and if PET scan would be available in like Dhanmondi, Mohammadpur, Shamoli, Mirpur, then I would suggest, and in our government hospitals, then I would suggest, because I don't offer my patients 65,000 taka to do
That's the
PET
problem.
scan in
That's the
Apollo.
problem.
Okay.
That's the problem.
In fact, the reality is those rich people doesn't come to me. Okay. And I can write, but I know that is useless.
No, sir.
He cannot go for it because of
Sir,
money.
the things will change. The rich people, they will trust also our system because there is
Yes.
some systemic fault. That is not our specialist fault. That's
Yes.
the fault from the system. So
Yes.
you are an associate professor in hepatobiliary surgery. You are doing quite well, and you are thinking about your patient economical condition also. You can just easily join a corporate hospital and give some to the money people. The money
Yes.
people who go abroad frequently, but we think your generation will lead this, and the people will come to you, and you become one of our Devi Shetty in hepatobiliary
Oh,
surgery.
thank you.
We
Thank
hope
you.
also.
Definitely things will change. Definitely, and it is changing. Patients are getting aware day by day. And if our government allows this PET scan in our government hospitals, definitely we will take the opportunity. Definitely. And now the
Thank
previous
you. Thank you for
topic.
your nice presentation, sir. Sir, Professor P.K. Shah, sir, can you just say something to us and to those people who are seeing this excellent presentation and tell something to encourage our next generation, sir?
Thank you very much. Thank you. I like to give my heartfelt thanks, speaker, Dr. Shubho, and I like to appreciate the participant for participating just webinar of today. And my few words regarding Whipples for webinar in today for the younger surgeon. Surgical responsibility is more. The burden of a surgeon should be reduced if we make a teamwork. Number one, if the young surgeon and ourselves, we have to make a team practice in hospital and private sector, that will be more easy to reduce the burden of our responsibility. One thing. Second thing, an evaluation of the patient and counseling of the patient is more important thing. Initially, the staging, stage 1 and stage 2, whatever procedure should be given, whether it is curative or palliative, you have to explain all the things to the patient. Otherwise, patient always, if the patient may develop complication or die, all the responsibility comes to our holder. This is very much painful. That's why I request to the younger surgeon always discuss the whole matter, complication and other things, good things and bad things, always to always discussed with the patient and his RT. That's why they believe the extent of depth and extent of complexity of the work. Second thing, whether Dr. Shubho very nicely explained the presentation, preparation of the patient, to meantime, and one question is arrived whether you have to advise for ERCP stenting or not. Question is two: biliary obstruction resulting to jaundice, biliary obstruction resulting to cholangitis. Two things. If the jaundice is only present, usually with stenting or without stenting, output is not so much hairy. But usually we are accept if facilities available, stenting may be done. But in case of cholangitis, I think stenting is better to reduce the inflammatory process, inflammatory condition with adequate antibiotic. Then during operation, tunnel of love, which already mentioned, which is called tunnel of love. If the tunnel is adequately plain between the supramesenteric vessel, pancreas, and total vein, it is the indication it may be operated. But the structure identification for the younger surgeon, it may be it is difficult. If the younger surgeon is very much oriented before starting the Whipple, partial aspectomy, common bile duct aspiration, right hemicolectomy, and if these three operations are usually oriented, then the structures of the uh, uh, around the pancreas, it will be more easy. Four structures, four vessels, we have to cut it. Four vessels. One thing is right, like that is pancreatoduodenal gastroepiphytic vessels, right gastroepiphytic vessels, and vessels of Henle. Four vessels comes into contact for cutting. Four structures you have to cut. One thing is the stomach, pylorus preserving or without preserving. Then the common bile duct, then pancreas, then small intestine, distal to the easy flexor. That means we have to memorize four vessels we have to cut precisely, and four structures we have to cut, then leading to anastomosis. Using anastomosis, which may be we are used to stand or not, it is depends upon the choice of the expert. I think if the beginner they want to start, my advice is you may give a stand, no problem. Biliary drainage, you may give a stand. Pancreatic drainage, you may give a stand. And maybe use, but you have to start with by teamwork and adequate equation. And if possible, so many experts in our country, so many general surgeons are also used to do the Whipple operation. But younger surgeons, I request you, you have to come in contact our senior teachers, and those are very much oriented in this big operation. And first of all, I give to thanks to the speaker, moderator, and participants, as well as the SCI and HTB also, giving the such an opportunity to exchange our news and views of the advanced operative procedure, Whipple's operation. Thank you very much. Thank you.
Thanks.
Thank you, sir. থ্যাংক ইউ। আজকের ওয়েবিনারে সবাইকে ধন্যবাদ যারা ওয়েবিনারের সাথে আমাদের সাথে ছিলেন এতক্ষণ। আমাদের আজকের টপিক ছিল Whipple's operation and technical aspect. I said Professor Akhtar Ahmed Shubho is a promising hepatobiliary surgeon in our country, and we enjoy his excellent presentation and also recommendation from Professor PK Saha sir, and I also give thanks to Professor Vidhan Chandra Das because sir also give us many topics on our table to discuss and make the discussion more interactive. And আর রাজ টিভিতে ধন্যবাদ টেকনিক্যাল সাপোর্টের জন্য। এন্ড এসিআই আয়োজিত আপনার স্বাস্থ্য সেবার আমাদের নেক্সট প্রোগ্রামে আপনাদের আমন্ত্রণ জানিয়ে এখানেই শেষ করছি। আসসালামু আলাইকুম।
ধন্যবাদ।
Thank you very much.
You
Thanks to
are
all.
watching Raj TV, Jagorone, Bangladesh. Please subscribe.